All right, you guys, what is up? My name is Dr. Tochi. I am an internal medicine doctor licensed in the state of California. I'm here to show you guys that are medical students or residents an effective way to do a SOAP presentation style. This is something that I've curated throughout my years of medical school, my years of residency, and then now that I serve as an attending in internal medicine, this is something that I've noticed that attendings like hearing. So I've kind of curated this presentation style to make you guys stand out. It made me stand out, and you really will make you guys really shine when you guys are applying for whatever specialty that you're going to be going into. So we're going to jump right into it. I have it labeled iSOAP. You might be wondering what the I stands for. We'll talk about that later in the presentation. You're going to need to start off by identifying your patient with this bundle here. One mistake that a lot of med students and residents make is that they kind of put a whole one-liner in the beginning of their presentation, and you don't really need to be doing that because that's something that you're going to be doing at the end of your presentation. So this is just a quick identifying factor for your team and for your attending. That way they know who you're talking about and can kind of like lock in into like whatever the presentation is going to be about. I'm going to give you guys an example. This is Mr. So-and-so. He's a 48-year-old male. This is hospital day 7, or he was admitted on October 25th, and he's here for heart failure. So you see how quick that is. It's a nice identifying factor. You don't really belabor every single thing, all their past medical history. We don't really need to be doing that. Just labeled it in that single way, and that will effectively start off your presentation. That is the first and most important step, is identifying the patient, hospital day, and when they're admitted, and then the overall diagnosis for why they're here. Heart failure, COPD, DKA, doesn't matter, just one singular thing. Next is the I. So this is the portion that I added to the iSOAP. It's interval events. This is something to kind of orient your team as to what's going on with the patient since you were last seen yesterday. Here we have a couple of things that I've curated that I like hearing. So one, overnight events. What happened overnight? Was there a code called? Was there medications that were given that were not expected? Was antibiotics started? Just mention quickly and briefly what happened overnight. If nothing happened, you can say no overnight events. Next, always talk to your nurse in the morning, especially when you're getting there early before the night nurse leaves, or if the day nurse is there as well. Ask them if there's anything that's going on that they've noticed, because they're there with the patient a lot more than you guys, so they can kind of give a lot of insights as to what's going on with your patient to bring up on rounds, so you can kind of clarify those certain points and unite all the interdisciplinary teams. Next, telemetry. If your person has like AFib or flutter or whatever sort of cardiovascular heart rate issue, always go to your telemetry tech or nurse and ask them, were there any overnight events that I should be aware of? And if there were, mention like, hey, they were in VTAC for like 8 beats, they were in AFib with RVR, and if nothing, just say no telemetry events. Next are 24-hour requirements. Now, this is something that I started adding into my own presentation, and it's really helpful for the patient in a whole holistic sense, because it may not be the reason why they're there, but it's something that you do have to keep on paying attention to. Those 3 things include insulin, pain medications that are controlled, as well as Ativan if your patient's in alcohol withdrawal. For the insulin, I say 24-hour insulin requirements. He required 3 units of Lantus long-acting insulin, 45 units of short-acting correctional insulin, and then I also mentioned their AM fasting glucose, as well as their glucose range in the last 24 hours. The reason why that's important is because having that insulin requirements as well as that AM glucose and range for the last 24 hours really gives us an idea how well we're controlling their diabetes. If someone has like really low or really high AM glucose that's fasting, that kind of gives us an idea how we're going to adjust the long-acting insulin that was given last night, if it needs to be increased or decreased based on that result. Next, what do we have here? So controlled pain medications. So this is something that I like tracking as well. In our EMR system in Epic, we can see like the 24-hour requirements of morphine, of Dilaudid, of hydromorphone, hydrocodone, any sort of pain medication that is controlled, not Tylenol or ibuprofen. I don't really track that. It's specifically controlled medications. I differentiate, one, was it oral? Was it something given by pill, by mouth, or was it something given by IV? This kind of gives you an idea how well you're controlling the patient's pain. Also, once you get all of those requirements in the PRNs, then you can kind of use that to adjust into your plan of how you want to put it into like long-standing controlled pain medications. So that's something that I also keep a track of in the 24-hour requirements. Next, Ativan. So we have CWAP protocol, which is a protocol that we start for people that are in alcohol withdrawal. It's given orally, also via IV. This is something that I like tracking day after day after day if your patient comes in with alcohol withdrawal, just to kind of see how they're progressing, and you can kind of track and kind of foresee when you think you can actually discharge the patient based off of how much Ativan's giving every single day to control a patient's withdrawal. So if you see if it goes from 12 of Ativan to 5 of Ativan, then 2 of Ativan, you can kind of notice that, okay, they're requiring less and less Ativan for the alcohol withdrawal, and they're probably getting closer to be discharged pretty soon, which is really helpful information. This is something that a lot of people don't mention as medical students or even as residents that I see now as an attending, and this is really helpful information to kind of gear up a patient for when we think they're going to be ready for discharge, as long as their other problems are controlled. Next, after interval events, we're going to talk about the subjective. This should be pretty brief. What I do is that, one, if you're not able to talk to the patient or get information out of them, always say why. So patient was intubated, patient was altered, patient was asleep, whatever. You should be mentioning why you can't get a subjective out of the patient. If you are able to get a subjective out of a patient, you're going to want to talk about, one, the chief complaint. Why did they first come to the hospital? Was it a chest pain? Was it shortness of breath? Was it nausea, vomiting? Was it abdominal pain? Always mention that first chief complaint, and is it getting better, worse, or the same? Next, you're going to want to talk about, is there any new symptoms that you're feeling? Do a complete review of symptoms of their whole body, and don't just mention all the normal review of symptoms. Just say pertinent things. So you want to say like new chest pain today, having nausea, vomiting today, having back pain today. Just say the pertinent review of symptoms. And lastly, always ask your patient if they have questions. This is really neglected by a lot of providers, and patients are sitting in the hospital wondering what's going on. So ask them, what questions do you have for me today? Don't say, do you have any questions? Because a lot of time that's not very inviting. So just say, what questions do you have for today? And just assume they have questions. And if you don't have the answers, take that with you and say like, hey, I don't know the answer to that right now. We're going to go talk on rounds and I'll get back to you on that. That's just going to foster a better connection with you and your patient. Next, we're going to go into objective. Now, this is a pretty beefy section, but we're going to break it down one by one. So first, you got to tell us if the patient's stable or not. If a patient has normal vitals, I just say stable vitals and move on. If they're unstable, then I mentioned the specific value that's actually unstable and leave it at that. You don't have to say all normal values. We are just listening the whole time as attendings to see, all right, where is the unstable vital? Is this patient worrisome or not? You don't have to like go through all the normal vitals if they're normal. And then also, if you have a patient that's in the ICU that's requiring continuous medications to keep their blood pressure up, such as Levophed or neosynephrine, that is something that I mentioned for the blood pressure specifically. So I would actually say blood pressure 80/50 supported by 2 mics of Levophed. This is the normal order that we like hearing vitals: temperature, heart rate, blood pressure. You got to give a range, specifically a range, your respiratory rate, your oxygen saturation, as well as the requirements. Now, the requirement means specifically nasal cannula, non-rebreathers, oxymax, high flow nasal cannula. If they're on an event, mention those settings. If they're on CPAP or BiPAP, also mention those settings as well. Moving on, in terms of other vitals, are the ins and outs, the I's and O's. So this is something, especially for our heart failure patients, that we like tracking. I always like making sure that the ins are recorded and the outs are recorded. So if your hospital has an order for strict I's and O's, I make sure that's in there. And then I also make sure those I's and O's are recorded every 2 or every 4 hours to make sure that you're getting actual values when you're diuresing patients. The net, so if it's net positive or net negative, so if someone has like in 1000 cc's and out 700 cc's, I would say net positive 300 cc's. And then I also say what the cumulative I's and O's are, which is essentially what the whole hospital course I's and O's are. Lastly, which is something that's very, very neglected, is when your patient had their last bowel movement. This is something you really, really want to keep track of, because a lot of patients in the inpatient setting get controlled IV opioids, which slow down our gut motility. So sometimes they can go 2-3 days without having a bowel movement, which is pretty concerning because you don't want to have them have a bowel perforation while you're here. So that's something that we really like hearing, to make sure that they're having normal bowel movements, so you don't get to discharge day and they haven't had a bowel movement in like 6 days and you're like, oh shoot, you can't just discharge them like that. Next, for the physical exam, For progress notes, I just like hearing the pertinent physical exams. You don't have to belabor a whole physical exam, just say the pertinent values. So I heard like a 2 out of 6 murmur. I see like 2, 3+ pitting edema in the lower extremities. I see this rash on their left arm. Just say the pertinent things. You don't have to go through the whole exam and just say normal findings. So the labs, I'm pretty particular on it in terms of what I want to hear. For the progress note style, I like only hearing 3 pertinent labs that you think are pertinent to the case that should be mentioned. So I would mention like the white blood cells, the potassium, the bicarb, the creatinine, whatever the case is, mention the top 3 that you think are pertinent. There's always going to be a lot more other pertinent labs. However, that can just be addressed in the assessment and plan. So we don't want to like go through every single abnormal lab value. We're going to be talking about in the assessment and plan, and ideally, everyone's already seen the labs beforehand, because not only are you pre-rounding on your patients, but your attendings are pre-rounding on their patients as well. So they've seen all these labs, just say the 3 pertinent results. Then when you were also mentioning lab results, specifically for the CBC and CMP, and then some other ancillary labs, always say if it's up or down from yesterday, especially like the white count 15, which is up from 12 yesterday, platelets 150, which is down from yesterday's 200, creatinines at 1.6, which is up from yesterday's 1. Just say if it's up or down. And then the other thing as well, when you're presenting labs, or not even just labs, your whole presentation, everything before assessment and plan, do not editorialize. Just state the facts, state the data, and move on, because the assessment and plan section is a time that you guys will be explaining and putting everything together. You don't want to waste time beforehand to explain what you think is going on, because that's not what that is for. So the next thing you're going to do is go into the microbiology. If there was a blood culture, a urine culture, a respiratory culture, you're going to say exactly the date that it was collected, when the most recent results are, what the results are, what the sensitivities are. You're going to mention all of those things. Next, you're going to go into the imaging studies. So you're going to go talk about your chest x-rays, your CTs, your MRIs, your PET scans. Especially for the chest x-rays, you guys should be giving your own assessments of your chest x-rays. I can do a video later on this channel to kind of give you guys my framework for going through chest x-rays, but give your own gross assessment. Don't just say chest x-ray read as this. No, you should be saying chest x-ray on my gross interpretation shows bilateral opacity, shows pleural effusions on the right or the left. Give your own assessment, because that looks more impressive than just reading out results. Because like I said, all this data is in the EMR and everybody read it, but sometimes things are missed. So you want to give your own interpretation. Next, cardiac studies, EKG, echoes, and cardiac cath results. The only one they should be giving your gross assessment on is the EKG. So give your gross assessment of what you're going on. Some attendings like seeing you going it step by step, but you should be giving your own assessment of what you see on the EKG. And if you're not good with EKGs, then go through it with your team and your attending and see if you are seeing something that you think that you are seeing, or if you're missing something, ask them if you're missing something as well. And then lastly, in the objective section, important medications and changes. You don't have to go through a patient's entire medication list that they're on inpatient. I would just mention the important medications that have been started and or have been changed. A lot of those things would be antibiotics, that would be cardiac medications, that would be hematologic medications. You want to mention all of those things in the medication section, and then also say for antibiotics when they were started, so we know and have an idea if a patient's septic, how long they've been on it for. Before we get into the next portion of the SOAP note presentation, I am going to kind of explain how long this all should take if you get really, really good at it. When I'm an attending, I try to limit my med students and residents presentations to 4 to 5 minutes max. I try to go a little bit more on the stricter size to 4 minutes. And if you're really good, you can do it in 3 minutes, but you should be getting all of this done. The interval events, the subjective and the objective, all done within 1 minute to 2 minutes. If you're able to kind of get it down in that efficient of a way, you're really setting yourself up really well for the rest of the presentation. So next, we're gonna go ahead and just flip this around and show the remaining portion of the SOAP note presentation. Next, you're gonna be talking about the assessment and plan. So first, the assessment. What our hospital likes doing is something called a problem representation. And this is kind of like an amalgamation of all the information that you told us before into a succinct, comprehensive, but meaningful representation of why that patient presented and why they're here. If someone comes in, you want to say, this is Mr. So-and-so, he's a 48-year-old male with a history. Say their pertinent history. Don't say every single medical history that they have. Don't say GERD, COPD, and diabetes, and osteoarthritis, and back pain. Just say the pertinent history that could be related to their chief complaints and their overall diagnosis if someone is here. They have a history of heart failure with reduced ejection fraction or coronary artery disease, substance use, whatever. I would say 48-year-old male with a history of heart failure with reduced ejection fraction, coronary artery disease, and polysubstance use, who's presenting with, and then this is when you would say acute, subacute, or chronic. Usually if they're inpatients, it's gonna be acute. Presenting with acute chest pain, mostly consistent with a STEMI. Try not to make this like a run-on sentence. I say to my team that if you're able to say an assessment statement, and this kind of varies, your patient's more and more complex, but I say that if you're able to kind of say it in one breath without taking a breath, then it's usually a pretty good assessment statement. Lastly, we're gonna get into the plan, which is your problem. The longer that a patient is in the hospital, the more and more specific you get with this problem. If someone's just coming in with undifferentiated chest pain, then I would say problem number one, chest pain, and I'll say my differentials are an NSTEMI, ACS, GERD, whatever. I say the problem, and then I give my differentials if it's still undifferentiated, and then I also give my evidence to say why or why not I think something else is going on. Always say your problem and then give your differentials. So don't just say chest pain, I want to consult cards and yada, yada, yada. No, say chest pain, I think it's because of this. So my plan is this. I like differentiating and separating the plan into diagnostics and then therapeutics. So I want to get an EKG, I want to get an echo, I want to get a chest x-ray, I want to do whatever. Say the diagnostic studies that you want to do. And if you want to consult someone, I usually put it in that portion too. Lastly, I put the therapeutics. So I'm going to give this person aspirin, I'm going to give them heparin, I'm going to put them on Lovenox. You're going to say what you're going to use to treat them in the interim. I hope that makes sense. You're going to say what problem it is. If it's still undifferentiated, give at least 2 to 3 different differentials, as well as evidence as to why you think that is, and try to put your money where your mouth is, and try to not anchor, but try to put yourself out there and put your nickel down on what you think is going on. That is more impressive as to just saying a whole bunch of different differentials and not really saying what you think is going on, because you really want to have a plan that's catered to what you think is going on. At the end of every presentation, I like to hear a summarized plan. And this is not only good for yourself because you're recounting everything that we've talked about while presenting this patient. After your attending kind of corrects you and lets you know if they agree or disagree with the plan. At the end, always say, okay, so what I'm hearing is that we're gonna consult cardiology, we're gonna leave them on a heparin drip, I'm gonna get an EKG and a chest x-ray. So you're gonna list out all those things for your entire presentation, and then just say, I just wanna confirm. And if they say yes, that is really good for you, so you know what to follow up on and to make sure that you're putting in the right order so you're not harming your patient. So always do a summarized plan at the end. That's money right there to kind of help you for your presentation and then for your to-dos for the rest of the day. Lastly is the bundle. This is something that I like hearing just to make sure that we're keeping track of it. If someone is on fluids, electrolytes, or nutrition, so are they on a continuous sodium chloride drip? Are they needing electrolyte replacements? Are they on a diet? The worst thing is to kind of hear that your patient's just been MPO for the last 12 hours, and then that's not really going to foster a good relationship with you and your patient. So make sure that they're on the appropriate diet. And then prophylaxis, are they on DVT prophylaxis is something that you want to make sure that they're on or not on. So sub-Q heparin, Lovenox, SCDs. And then lastly, you want to talk about their code status, especially if they're DNR, DNI, or comfort care. So this is the most effective way to do a SOAP note, progress note style for your patients on the inpatient services. If you present it in this style, making sure that you identify your patient and say the hospital day when they're admitted, why they're admitted, and then go into the interval events, saying overnight events per the RN, telemetry, 24-hour requirements. Specifically, these 3 things are really big money: insulin, controlled medications, as well as Ativan for alcohol withdrawal. There's subjectives, going through all of that. Objectives, saying everything. If it's stable, just say stable. If it's unstable, say what is unstable. Don't just belabor every single normal vital if it's normal, because that's just wasting our time. Eyes and nose, say the net positive, net negative, cumulative. Give the last bowel movements, do not forget that. So you won't want to have that being forgotten. Physical exam, just say the pertinence, say just 3. abnormal, pertinent labs. Don't just say every single lab, because you can talk about that later in the presentation. Then do your micro studies, then do your imaging, cardiac studies, your own interpretation of the EKG. Important medications and medications that were started, with the caveat with antibiotics being mentioned when they were started, so we know how long they're on for. Then for the assessment and plan, give it a problem representation. Do your plan, give your differentials. For your plan, make sure that you give your problem the 3 differentials, what your evidence is to say that. Give your diagnostics and your therapeutic plan for every single problem you have. At the end, make sure you summarize your whole plan for the patient, so you have a list of to-dos to know what to follow up on, and then give your bundle at the end. This is my advice after being in internal medicine for the last 4 to 5 years. I feel like this is money information. If you guys are medical students or residents, this is really gonna have you stand out. Like I said, if you're able to do this entire thing within 4 to 5 minutes for every single one of your patients, is really gonna be making your rounds efficient and really gonna help you understand your patient even more. So I hope this was helpful. Go ahead and subscribe if you guys want more advice like this. I can do more whiteboard talks. And if you have some requests, put them in the comment section down below. Go ahead and check out the video in the top right-hand corner to see some other videos of mine. If you guys are interested in content like this and medical students, residents, or even doctors out of residency, go ahead and subscribe, and I will see you guys later. Peace. Have a nice day.